Hey everyone, thanks for sticking around with us. Next session is posterior malleolar fractures. Tara is going to be walking us through that as moderator. It's yours, Tara.
All right. Hey everyone, I'm Tara Moncman. I'm a foot and ankle surgeon down at Rothman in Florida. We're going to be talking about posterior malleolus fractures. Just wanted to thank my panelists here. So we have Sergio and Atif. They're both trauma surgeons at Rothman. We have Erik Freeland. He's a foot and ankle surgeon at Cooper. And then we have Lara Atwater, who is a foot and ankle surgeon at OHSU. So let's get started. And you guys, panelists, just chime in if you think of something, but I'll try to facilitate the questions along. All right. So our first case, it's a 68-year-old male. He's relatively healthy. He falls down 2 steps and has left ankle pain. All right. So here's the x-rays that we've got. What do you guys want to get a CAT scan? Sergio, would you get a CAT scan with this?
So typically when I see a posterior malleolus fracture or any type of fracture goes towards the posterior medial aspect, I like to get CAT scan just to assess my fracture pattern and plan for my preoperative approach. So yes, I will get a CAT scan.
What about you, Lara? Would you get a CAT scan?
Yeah, I mean, I'm zooming in. It looks like there's sort of a partial articular, like posterior malleolus fragment there. Like sometimes it's just that back posterior piece, but that actually looks articular. So I think I would get a CT scan. Sometimes if the articular surface looks okay, like I'll just pull that posterior mal down and do an A to P screw. But for this, I'd get a CAT scan.
Atif?
Yeah, I would get a CAT scan, but not really as much for the posterior mal, but it looks like there's like a posterior medial fragment on that mortise view. And so I would do it more to look at that than the posterior malleolus itself, because it doesn't look like something that I may have to chase, but we'll see what it shows.
All right. Erik, can you hear us? Are you on?
Yes, I can. Yeah, and I would absolutely. I think this is my case. I would absolutely get a CT. Yeah, it does change the operative plan. There's a lot of literature to support that, and it seems like at my institution, if you walk through the front door, you get a CT. And I've found this in non-bias and looking at the X-rays. I do find looking at the CT afterwards, it definitely changes the operative plan. So I'm a big proponent of that.
Yeah, I kind of agree with that. I think sometimes I see it on X-ray, and then I just, I'm just starting out, so I get the CAT scan just to be safe, and then I'm surprised at how, big or the posterior mal is, or that there's some articular step off. So, so in terms of the CAT scan, do you guys have any cutoffs? Like it involves a percentage of the articular surface, or do you just kind of look at the X-rays and based on your experience, you get the CT scan or not?
If I see a posterior malleolus fracture, I will generally get one, regardless of size, just to better formulate an operative plan. So I have a very low threshold to acquire one, as long as it's not going to delay definitive management.
Yeah, and I would second that. Like anytime there's a posterior malleolus fracture, I always try to get one. And if it looks like it's just about bimal or lateral mal, I don't need it.
Yeah,
Okay.
I'm 4 years into practice now, and I think at the beginning, like CT scans were really helpful for me. One of the hospitals I take call at is more of a rural community hospital, and I don't necessarily know about the fractures like when they're in the emergency room. So it can be a really big deal to like send the patient to the hospital to get a CT scan, like, while they have this fracture. So I've been doing less of it, sort of the more experience I get and the better idea I have of like what I'm going to find, I think.
Nice. Sergio, any additions or just agree?
No, I agree. If I see a fracture going towards the posterior side of the tibia, I definitely would like to get a CAT scan. Just have a better idea of understand the fracture pattern and plan for my operative approach. So a very low threshold for it.
All right, so we got a CAT scan, and here's what it shows. And again, we're going to focus on the posterior mal. So when we start to think of plans, we can, talk about the whole plan, but we'll just try to focus more on the posterior mal. All right. We'll just walk through some of the cuts. Are you guys seeing anything that's starting to make you think one way or another in regards to your approaches, the fixation you're going to use? Sergio?
When I look at this, first of all, is when am I going to go posterior lateral, posterior medial? So
Mhm.
looking at this, I would like to go posterior medial to address those posterior medial aspect of the medial malleolus fracture and also address that posterior malleolus. And then I start to think, am I going to have to go between the tibialis posterior and the digitorum, or do you have to bring everything else more anterior and go between that and the neurovascular bundle? So those are my thought processes of how I'm going to address this fracture.
What about you, Atif?
Yeah. Can I see the 3D recon again?
Yep.
So, you can, for me in my hands, like if I was going to address these pieces, which I probably would, I would do, I do probably a posterior medial approach for sure, and then see what I can get through there. And then I should be able to, when I put the plate on the back, go all the way to the lateral side. And so it'd be posterior medial for me, and then a separate incision for the fibula.
Yeah.
And you guys find it's pretty easy to get all the way over to that lateral side when you do that posterior medial approach? You have any tips for the audience?
I mean, it just needs a big cut, so don't be afraid to do a big cut. Your incision starts distal to the tip of the medial malleolus, and then just make it really, really proximal. The posterior medial approach is really, really nice and very versatile, because when you make it very big, then you can see the entire posterior aspect of the tibia all the way to the lateral side to the area of the syndesmosis. And then you go through, and then you use that interval between the posterior tibialis and the digitorum, and that will get you good visualization. But like Sergio said, if you need to go all the way over, then you need to use the interval between the digitorum and the neurovascular bundle. And that doesn't bother me anymore. It used to stress me out, but it's really not that big of a deal.
Yeah, I agree. Just make sure you make a big incision. And in my fellowship, we didn't use that much tourniquet, and using a tourniquet for this helps a lot too. So I'm starting to start using a tourniquet. But it all depends on, sometimes I don't use it because I forget, but if you're able to really get back there and move your neurovascular bundles, like it's really not that scary once you identify your nerve and just completely, move it to the side. And after you do like a lot of these, you feel more comfortable. It's better than, I think, the posterior lateral. I struggle a lot more, especially if you have to really internally you really have to rotate that leg, and if the patient doesn't have a good rotation at the hip, you struggle a lot more. So for me, I think the posterior medial has been better than attacking it through the posterior lateral approach. But for this fracture pattern, definitely more of a posterior medial, because you have to address that posterior medial aspect of the medial malleolus fracture as well.
Yeah, I think that's a really good point. I think that we'll go through some cases that we can discuss that posterior lateral versus the medial approach a little bit more, because it's really hard to get medial with that posterior lateral approach. So what about positioning then? You guys have any special positioning tips?
Enough for this. I just keep them supine, make sure I'm able to rotate the leg. If I'm struggling because I can't get the patient to rotate, then I have the bed tilted. That's been helping me, or start to bump the other side of the leg. But I've been okay on, like, preoperatively being able to rotate the hip. I could get back there.
Just a lot of external rotation at the hip. Sure.
Yeah.
Okay.
For me, if I'm going to go in the back and I'm doing a posterior approach, I always just go prone. It's just so easy.
Even for posterior medial, you'll go prone?
Yeah. Oh, yeah.
Anyone else? Eric, how'd you do this? What was your approach for this one?
So it was a posterior medial approach, and I did position the patient supine. I do put a bump under the contralateral hip to get more external rotation on the involved limb. I agree with everything that's been said as far as using a bigger incision. I think as I've evolved, my incisions have grown a little larger just for improved exposure, and I like to work through two windows, both of which were mentioned. The biggest struggle I have found with it and doing more posterior medial approaches over the years is still getting over laterally to key that lateral malleolus piece in, or the lateral component of the posterior malleolus, I should say. And so that part, I like to do it supine over bone foam with the contralateral limb externally rotated as much as possible, and then using a bump too, because it's really hard sometimes to get down and to reduce that piece and to really get the drill down to get in the right trajectory.
And then how about mini or major C-arm? So in training, and trauma is always major C-arm, but then every foot and ankle surgeon I worked with, they'd only use mini C-arm. So I'm curious what you guys think.
I don't know how to use a mini C-arm. I think I always feel like I'm going to contaminate it. I rather have someone help me with the C-arm, and you have a good X-ray tech. You train that X-ray tech, and they're able to get you a good mortise, even the patient's all rotated. So that's why with this case is I wouldn't be doing in the middle of the night. I have everything planned with the X-ray tech that I know and the C-arm that I know. I wouldn't use a mini C-arm, but I know what you mean. A lot of foot and ankle do like to use the mini C-arms.
Yeah, Lara, what do you do?
Big C-arm.
Yeah, a big C-arm. Like in my foot and ankle fellowship, like all we used was the mini, like period, for everything, like even posterior approaches, like mini C-arm. But like when I got to practice, like I was on the same day as a hand surgeon who used the mini C, so they made me start using the big C for like everything. And now we have 2 mini Cs, but I can't go back on the ankle fractures. It's just so much easier to use a big C-arm. So I don't think I'll ever stray.
I totally agree with you. So, in training, you always have extra hands, right? Like you're the extra hands, and then there's just more, right? And I'm starting out and I have no extra hands. So I was started off using the mini, and then one day I was like, I'm just going to do the major, and haven't gone back. It's so nice. Do you guys have tips for getting
the big C-arm?
Yeah, go ahead.
Yeah, no, so the key thing about the big C-arm, it's not as critical as for ankle fractures, but it's like really the only way to make sure that you have a good alignment of the plafond, and it really helps me ensure that the fibula is out to length, and it gives me a good general picture, because otherwise you can lose the forest and the trees with when you're not seeing as much, for sure.
Yeah.
I like big C-arm too for all fracture work, but mini C-arm for non-fracture work essentially. But I shouldn't say that, because all for fusions and arthroplasty are still big C-arm for me.
Do you guys have any tips for getting like a better AP view? Because I think it's a little tricky, especially if you don't have a good X-ray tech that really knows what they're doing when you're in the prone position.
I have them rotate over the top so I can and rotate the leg as much as I can. It's a struggle though. That's one of the things I hate about the prone approach.
Yeah, that's the key thing. It's kind of a struggle, but I use a dive board table, so it's not like a regular table that has the metal pieces on the sides. So you can rotate the C-arm as much as you need to get your good AP and a good mortise, because you just can't. Otherwise, you can't internally rotate the ankle that well in the prone position.
Yeah, I think the dive board is really key for me too. Once before I scrub, I make sure I'm able to get all my X-rays with the tech that I'm working with. And then we say, okay, that's the AP, that's more just lateral. And knowing your tech and knowing how to get it really becomes easy after you plan that ahead. It takes an extra 5 minutes, but I think it saves a lot of stress when you're in the operating room, you can't get a good X-ray.
All right, so here's what we've got. What do you guys think? Eric, do you have anything to add?
The only thing I'd add to the conversation about X-rays is that we recently obtained a 3D X-ray machine, and that's been pretty cool for doing really posterior pilon work in general, but it's a little cumbersome. There's definitely a learning curve to using it both for the physician and the X-ray tech. So, but it is something neat to explore if your institution has one.
Yeah, if I was
Definitely.
able to get a 3D seam, whatever machine it is, but the 3D is definitely something that I like to push for in where I am. But yeah, having that 3D, being able to understand whatever, like it does help a lot more. I'm jealous of you, Erik. That you have that.
I have an O-arm, so it's a little bit more cumbersome. But when I really need it, I just pull the trigger, and then everything moves really well to get it in. So definitely.
Nice. Okay, let's move on to the next case. So this is a 68-year-old male. He tripped over some broken sidewalk. Again, relatively healthy. And here's what we've got. So pretty standard ankle fracture. You can see this is the pre-reduction film. I think, would everyone get a CAT scan here?
I really like to get reductions
Totally.
first before I
Yeah.
get the CAT scan. I like try to get that back, but sometimes you don't get that privilege to do so.
Yeah.
But I get a better understanding of the fracture once the joint is reduced.
All right. I agree with you, but we don't have those. So we did get the CAT scan here, and here's what that posterior mal piece looks like. So what are you guys thinking off the bat? Obviously fix it. You guys thinking plate, screws?
Can you go back to
For me, it's always a plate.
Yeah, it's asking to be buttressed.
Your lateral approach.
And do you have any, so because of the size, like what leads you more towards a plate posterior lateral approach versus maybe doing some P to A screws and getting that down?
It's sort of multi-fragmentary, and so like a plate's gonna sort of compress that a little bit more effectively and broadly than a single screw. Like, and it'll be nice to sort of get a look at it and put that back together through a posterior lateral approach.
Yeah, guys, my indication is when there's articular step off, and then you see a little triangular piece.
Yeah,
and you're looking
exactly.
At the
I would put that back first and then rebuild it.
Yeah, and I treat those
Yeah.
like I would almost with true pilon, where just going back in and through and opening up that fragment and reducing it and then buttressing it down. If it's a straight piece, if it's one piece that I think can be sufficiently reduced without having to restore the articular surface through multi-fragmentary pieces, then I'll just put, then AP screws I think are sufficient. But given this, and especially bone quality issues too, just trying to disimpact that and restore the articular surface, I think is paramount.
Yeah, agree. I think that would be my concern. I'd be worried that if I tried to get that down without having that posterior lateral approach, you'd really struggle.
But also
What do you
looking
guys-
at your pre-reduction X-rays, you can see how that tailor is trying to dislocate posteriorly. So that's majorly what you need to control on that piece. So putting a screw is really not going to help you. I mean, it's not going to be as favored biomechanically to stabilize that piece and trying to stop that subluxation posteriorly. So putting the screw for this type of fracture pattern, I'll be suboptimal. I would think, but kind of putting that buttress plate would be nice to hold that from subluxing posteriorly.
Hopefully when I show the imaging, there's not a screw back there. You guys are all pro plates. Just kidding. All right. So here's what was done. So I think, I forget who did this one. Was this you, Atif?
Oh, this one's mine.
No.
Yeah. So looks great. Do you have any reduction tips? Right? Because like we talked about, it was multi-frag. There was that articular step off.
Yeah, and even to the lateral malleolus, it extended down almost in a T shape all the way down to where the CFL originates. And it made it definitely more difficult. So we did prone posterior lateral approach. We got down, actually, I also realized our bone quality was fairly poor. So what I like to do with these, though, in general is, the old adage was to fix the fibula first. And so we really go against that when we're doing through the posterior lateral approach, just because we want to see our articular reduction. So I will provisionally reduce the fibula with a clamp. You just can't see it in this picture here to the left. But then once I get it reduced, that usually helps to bring your posterior malleolus piece back out to length and reduce the articular surface. And what I do is I leave the PITFL intact and just go medial to that and open it up and really disimpact everything, restore the articular surface, and then pin it all back down, and then place this is like a 2-7 plate from the mini frag system, and then buttress that down. And then I still like to lay the plate laterally to avoid any irritation of the peroneal tendons. So I cheat my incision a little bit laterally in order to accommodate for that. And then sometimes I have to perk the screws distally depending on the orientation of my incision, but usually I can slide that plate and usually retract the soft tissues enough to get the screws in laterally to avoid a direct posterior plate.
What about anyone else? Have any good reduction tips for how you?
So for people who have been, obviously these are really nice to fix when they're pretty fresh, but if like in the sort of 2-week, 3-week-old ones where everything is really short, like I think those are the most challenging one, especially where like, the patient has vitamin D deficiency, which is everyone in Oregon, and they're a smoker. The one thing I started using for the fibula is a cast bar. It's basically like a pin distractor that you can use to sort of get ligamented taxis on the fibula, but it also helps stretch out all of your posterior lateral like soft tissue structures in addition to the fibula. So like sometimes if you put that on, leave it, like keep distracting. You don't have to like leave it on there while you go to the posterior mal, like that'll sort of help give you some soft tissue pliability when you go to the posterior, and you don't actually have to leave the pin on there, because I've gotten in trouble when I've used a clamp to reduce the fibula provisionally, and then the bone's just so crappy that like it fails through the clamp, and now you have a comminuted fibula and you don't have you don't have a fracture read anymore. So those pin distractors have been really helpful, especially for old fractures and bad bone.
I like that. That's a good point, especially when you don't work in a trauma center. You are getting those 2-week-old fractures.
Yeah.
Then they need medical clearance. So then you're not fixing them until, like 3.5, 4 weeks. So
right. And if you don't have, if you're not operating with an assistant who can help distract the fibula, like the pin distractors are really useful because you're doing it all by yourself.
nice. All right. And then there's the post-ops again, which I think looks great.
Yeah.
Everybody agree? Any other comments?
Looks good.
Thank you.
Yeah.
Next one, 45-year-old male, falls off his deck, right ankle pain. So here he is, injury films, and we do have post-reduction films here. All right. So let's go through it again. Everybody, yes, CAT scan?
Yes.
Yep. All right.
Totally.
All right, so here's the cuts that we have. What are we thinking? Plate, obviously. Posterior lateral approach. I know it's a little tricky because I don't have, all the CAT scan cuts for you, but do you think this reduction is going to be tough to get it compressed with those, multi-frag pieces there?
So yeah,
Sergio.
for me,
Yeah, I think the piece is going to run interference
Yeah.
between your reduction. You have to open it up to get that piece out, especially where you see on the second image there.
yeah, this is one where I think this is my case, so I could talk about how I approach this. But
Okay.
that was a piece where, like what Eric was saying, that is going to affect my reduction. So for me, definitely posterior medial approach to be able to see that, and you actually be able to get a direct visualization where that piece will go. And once I'm able to disimpact that, then be able to bring down my posterior malleolus and then buttress that over. With the bringing the fibula out to length, I completely agree with that. This was nice because I operated this right away, so I was able to manipulate the fibula without having to open up that lateral side right away. So just by pulling traction, I was able to bring that back and held it with a K-wire. And I like to use the 2-4 plate system because I feel like a contour around it. And once I'm able to bring it down and I buttress it, then I start feeling better about this fracture.
So do you routinely use like a big reduction clamp like this?
Not routinely with these. It was just that I was finding that I couldn't have a good I couldn't have anything else hold it. So I made a little stab incision, and then I was able to bring it over and I just clamped it and it held. So you just have all these different clamps available. For one time it'll work, some time it won't work. But whatever helps me with. Sometimes I'm able to reduce it and hold it with K-wires, but it was hard to do that because it was comminuted and I could only get a good little 125 wire just to hold that piece. And then over the plate, just to hold the plate as well with the clamp. I remember this case, it was nice just to hold it there. It's one of those things when you feel that, okay, just move forward and keep going, just put your screws in and then go over to the lateral side.
Yeah, so that posterior medial like comminuted fragment there would, it'd make me worried if you don't get direct visualization of it on the articular side. So do you ever throw a scope in to see what your reduction looks like?
I don't think I've ever used the scope as a trauma guide for the ankle.
Yeah. I kind of knew that answer was coming.
I did.
The little nanoscope.
I scoped ankle fractures a lot more in the beginning.
I've used the nanoscope one time.
Yeah.
Gotcha. Well, I don't scope these prone, but sometimes when I feel like there could be loose articular fragments and stuff like that, I will scope it quickly from the front, and then you can always like go back in to sort of check your reduction. I do less of that now. I think in the first year or two of practice, it was as much a learning tool for me as it was an excuse to like go and fish stuff out of the joint.
Yeah, I hear you on that. I like you doing a scope. Definitely as a learning tool a little bit. What about you, Eric? Do you scope at all?
I've been scoping more for fracture, especially, all bimalleolar equivalents and Mason Ooze I'll scope, but for posterior, if there's a small posterior malleolus, and I'm on the fringe about fixing it, I will insert a scope. Also, some of the, if I'm supine, I haven't really developed a methodology in my head, at least, of how I would be able to scope from a prone position. The nanoscope either, which I think does have a utility to slip that into the joint to assess the articular surface, but with the standard 2.7, I struggle to do it prone.
And then on these x-rays, the articular surface looks really nicely aligned. Does anyone get a CAT scan afterwards just to make sure that your reduction is as good as the x-ray is showing?
I don't, because at that point, you're not going to go back and change anything you kind of don't want to know, frankly.
Yeah.
I don't think it'll change my, like what Laura said, I went in there, I was satisfied with my reduction, and then I think the CAT scan, maybe it'll just give me more agita at the end of the day. So
there's a little bit of this.
Yeah. What about, yeah, go ahead.
Oh, no, I was going to say, I think there's questions in the chat whenever you get a chance.
Oh, okay. So this is for Lara. Where do you position the pin distractor on which structures?
No, basically in the fibula, just sort of on either side. Keep in mind that with like I use a lot of Paragon, and they have like a cast bar pin distractor that you can sort of twist, and so you can it's not just like a single plane like a Hinterman, like you can kind of twist through it, because all of these fibular fractures are going to be rotational and not just like straight shortening. But basically I'm not doing it to reduce the fracture, I'm doing it for ligament taxis and to restore length. So often I use it to stretch things out, and then I'll sort of like take the distraction off and let it sort of collapse and rotate into place when I'm reducing the fibula. And then what I was explaining before, the posterior mal, sometimes just distracting the fibula and holding that at length can help distract the other soft tissues that are going to hold up your reduction of your posterior fragment. So you might even like take the tension off the pin distractor, and it's still going to be easier to get your reduction, just because the soft tissues are all loosened up now.
And
Did
then
that answer your question?
I guess we won't really know, but hopefully they can respond to that. And then the next question was, any thoughts on fibular plate positioning from the posterior lateral approach? Some worry about going to lateral and causing wound healing issues. So I guess when we were talking about doing a little bit more of a posterior lateral approach and putting that plate lateral.
I think if your incision's long enough, like it's not going to be a problem, basically. Like you'll be able to
I would say for me, yeah, go ahead, you can finish.
Well, no, I mean, I've also, like, I'm not a huge fan of posterior plating. I mean, sometimes the fracture just begs for it and you have to do a posterior plate. But I've also had patients who have had, like perineal tendon issues, and, so they're like 6 months out and they have like sharp searing pain, and like, it's because their perineals are chewed up and you can't get an MRI because there's going to be too much scatter from the MRI. So you just have to go in and take out the plate and repair the perineals that are chewed up because you chose to do a posterior plate, not a lateral plate. So that's my bias.
Yeah, Greg, I've seen a.
Yeah, I mean, for
okay.
me, I love putting the posterior plate on because it goes through the same incision and you're staring just at the back of it. And you can avoid the perineal tendon issues if you don't put it very distal. So
Yeah,
you can't put it as distal as your regular lateral plate. So as long as your fracture is amenable to it, a posterior plate's not a bad idea.
Yeah, I agree with that. As long as it's not too distal and within that retrofibular groove, I think it's okay. But if it's too distal, I think that's when it runs interference and crowds out the perineal tendons.
Definitely.
Yeah, I always feel like I want to put it more distal.
Yeah.
But then I look on x-ray and it's okay, but you just want to move it a little bit more distal, but it's just more soft tissue disruption. And then you worry about the perineals. So I don't know, the lesser of two evils, I guess. And then, what about the positioning of this plate on the posterior mal? So my worry is putting it distal and then getting that like post-op stiffness, right? I don't know. I feel like I saw a lot of that in training whenever you use that posterior lateral approach, that patients get pretty stiff afterwards. Do you think it's just the approach itself or the plate positioning? You guys have any thoughts on that?
I think they really do get scarred in back there, which is one, I guess, could be the argument why some people would like to use their AAP screws. But I try to move them like right away. Even in their splint, I beg them to move their toes. I tell them, like, I even talk to family members to just continue to dorsiflex the toes, continue to dorsiflex the ankle, even the splint. And I think they do get a little bit more stiff compared when I have to go back there. But I mean, like, you have to be able to address and stabilize the fracture. So it's one of those things that I talk to patients about. For the any thoughts on that? What do you? I mean, I do experience that they do get stiff.
Well, they definitely get stiff. I think even more so with the posterior medial approach. That's a good point. I agree. Have them move their toes, because you keep the deep flexors moving in the back, it probably can prevent some adherence to scar tissue. But I like to get them moving too early rather than putting transition from a splint to a cast to try to get them into a boot at the first post-op visit and get their ankle moving.
Yeah, really the key to this is you got to get them moving as soon as possible. And for me, it's right at that first post-op visit. Stitches come out, they come out of whatever splint they're in, and then they got to start moving it. And I tell the patients, like, we're going to give you a cam boot, but I don't want you to wear it unless you're just going out in the world, and just so that people know you got a bum leg. And that's it. That's its only purpose until you are allowed to weight bear.
And I'm pretty aggressive with weight bearing. I see them 2 to 3 weeks. If the incisions are healing well, I let them start walking on this. I think it helps with their decrease of risk of stiffness.
I agree. I've evolved and become more aggressive with weight bearing. The earliest 2 weeks in some folks too, but depends on a host factors too. Whether in bone quality and how good I feel with my fixation as well.
Yeah, I think those are all really great points. I do the same thing. Try to get them out of the splint into a boot and just tell them the boot shouldn't be on unless they're like out of the house or up on their knee scooter. And then I do start them in physical therapy at 4 weeks just for range of motion and, some edema control. But all right, let's go to the next case. All right, 41-year-old female falls off the back of a pickup truck. Here are injury films, post-reduction films. And of course, we have this nice writing here, like we all know from the radiologists that like to put their little measurements right at the fracture so we can't actually see the fracture.
Mm-hmm.
And then you can't get rid of them. It's so frustrating.
I know. Totally.
So pretty big posterior mal. Everybody thinking CAT scan, I'm sure.
Mm-hmm.
So here's what we've got. And I feel like I see a lot of this type of pattern where it's like that posterior mal piece and then it just goes all the way over across the posterior medial aspect as well. I don't know about you guys, but.
Oh yeah. I think the advent of CT or the increased utilization of CT has brought forth the attention to posterior pilon fractures, and that's why we're seeing a higher frequency of them. But like on those initial injury films, too, you kind of see that misty mountain sign, or if I see a double bubble sign. Those are very low thresholds to get the CT.
I'll go back so we can see. Yep.
Yeah, right over the medial mal.
Yeah.
Yeah. When I see the double bubble or the misty mountain, which is actually both, then that's your pilon requires a CT.
All right. So, Lara, what are you thinking in terms of your fixation, your approach, positioning?
Yeah, I mean, I think I would still go posterior lateral for this. Like, I find posterior lateral can be pretty powerful even for medial stuff as long as you're prone. If you're trying to do a posterior lateral approach supine, then like forget it. Like it's really hard to see anything. It's hard to drop your hand low enough to like get your screw fixation. But you can probably do both through a posterior lateral approach provided that you're prone. But
yeah, and let's say you're posterior lateral and you're like, nope, I can't get medial. I'm going to have to make a medial incision here.
yeah.
Will you like just close and flip? Do you put go upside down, like bend the knee and just kind of do it upside down? If you're like,
no, I think you can probably just
rotate
even
the
if
leg.
I'm doing it prone, you can just go over to the medial side and do what you got to do there.
Yeah. Yep.
Yeah, I mean, unfortunately, that piece does need to be pulled down. I mean, sometimes with this pattern, like the medial mal, like is pretty non-displaced back there in terms of a proximal distal shift. I don't know. I have like a community partner who's a generalist who's like a big proponent of non-op treatment for medial mal fractures. like these do get better if you leave them alone, as long as they're not walking on it at 2 weeks. And so he's, with the stiffness of, posterior medial plating and all that stuff, he argues for leaving some of that stuff alone, which feels really weird. But
Yeah.
I kind of think he has a point sometimes if it really is completely non-displaced, like usually there's an anterior collicular fragment that you need to put a screw through or whatever, but for that little posterior medial shell that's just sitting there, I don't know.
It's just
I
so hard to look
struggle
at that though.
It is. You just want to go back there and slap a plate on it. But
Yeah.
the question is, do you have to? You definitely don't put a screw in it because it's usually really thin, and that screw will just probably, it could break it in 2 pieces. So I wouldn't put a screw in it. But anyway, it's a non-traumatologist, non-foot and ankle perspective to throw in there.
Yeah, I do get it though. It's sometimes very anticlimactic when you see the medial piece that it really is like that thin wafer shell, and then you put this little plate on it, and then they have another. Yeah. Okay.
Which is why I usually only chase those posterior medial pieces if it's attached to a articular surface. If it's not attached to articular surface, then you're going to be really safe leaving it alone.
All right, so I think this was yours, Atif, right? So what approach did you use? What did you do?
I don't remember. Can we see the post-op x-rays?
Yeah.
There's
well,
so
what
many
would you
of
do?
them.
No, let's test yourself. What would you do?
So I think what I did for this is that I put him prone. It's a posterolateral approach. And so I like to use, it's a younger patient, and so I'm very comfortable using the mini frag system to get the plate on there to use it as an effective buttress. So as you can see, I think with one of those fluoro shots, if you go back to the first fluoro shot, so like the sequence of events is I always go to the tibia first, and through my posterolateral incision, I start medial and then I work my way lateral. So I always get the fracture reduced down with like a little ball spike pusher, put a K-wire in it to hold it provisionally, and then start using my AO principles to get the buttress. And so that's the medial plate. And then if you click forward, so then put another plate laterally to now stabilize the lateral part of the fracture. And then once that's done, like the fibula starts coming back out to length, and I'm a posterior plater of the fibula when I'm through this incision. I just take it's through this incision, it's safe, and then I will use a 1/3 tubular plate to then buttress the lateral malleolus. And so it's a very trauma surgeon-esque way of dealing with this. And then you can see I added another plate a little bit more medial just because I felt like I wasn't as medial as that medial fragment was. So it got another extra mini fragment plate.
Yeah, I love this. How did you get so medial? You just made sure the incision was nice and big. I think it's really hard. You can get the plate on, but then your screw trajectory. I feel like when I'm trying to like throw the screws, just all the soft tissue's in my way. Like
Are you prone?
Yeah.
Huh?
Okay.
Yeah, it's with a lot of salty and heartache.
Longer incision, I guess. Huh?
Yeah.
No soft tissue on the back of the tibia.
Oh god. Yeah. I'm not that brave
Yeah.
yet, I guess.
You'll get there.
So, yeah, you don't have to worry about it. And like the thing is, like I have one of the beauties of, even though it's private practice, we have so many really well qualified hands in the OR. I can have a person that's like really managing the leg position. I can have another person that's holding retractors. I'm doing the surgery, and then I have a C-arm tech that's like really good. And so I'm kind of spoiled in that sense, and so that I have a lot of hands to do things that I wasn't able to do other places. So yeah, it's just big incision, really taking that FHL and moving it over, putting a couple Bennett's back there, and baby Bennett's, and and anchoring it on the medial aspect of the distal tibia, and then bringing that over. And so all of that is really just pulling a lot of tension on the muscle, and the skin is all very safe, and so the wounds still heal really well. The key is just a big cut.
Yeah,
And then-
and going prone on this, because if you try to do like even a sloppy lateral on this, it'll be very hard to get back there. So I wouldn't, if you want to go all the way medial with the posterior lateral, I think supine will be very challenging.
Usually.
Yeah, and so I always go prone. The OR staff hates me because they do the positioning. I'm not involved in positioning or prepping and draping. So I make them put the patient prone. These patients I find that have posterior malleolus fractures are usually, they're on the larger end of the spectrum of patients that get ankle fractures.
In a hole.
Mm-hmm.
Like, yeah, I've out of, in the last 5 years, I think I've only had one person that was like not large that had this fracture.
Mm-hmm.
So it's just an anecdote that I've had, and so it's always difficult. But once you get an idea and you get used to it, then it's not so bad. It's another day at the office.
I also like that you use these plates truly in the buttress fashion, right? Because I feel like you see a lot of times you see screws along the distal aspect of the plate when technically, right, we're just buttressing. You don't really need the screws distally. Are you always just buttressing like that and not bothering with screws distally? Or is it?
I will do this for younger patients. I think this girl was like probably in her 30s, if I remember correctly. And so for older patients, I always will wrap the joint with locking screws. Just to give it that extra oomph that it's definitely not going to go anywhere. But in young patients, good bone, I'm really like when I cinch down those first screws to get the plate to buttress, and you get that rock solid bite, then I know that I don't really have to put in anything else distal as long as everything else looks good.
And then what does everyone think about the mini frag plates? Would everyone use mini frags? Would you use like a standard ankle peel-on plating system here?
I like to use the 2-4 mini frags because I could really contour around, and I do a little bit of a bend, but I rely on the plate bending to buttress that segment. So the big peel-on plates are pre-contour, and it's really, for me, it's hard to actually do that true buttress with it. So I like the mini frag plates.
Yeah, if you go back to the X-rays, so I kind of combine things. That plate that's the most lateral plate on the distal tibia, it's the Synthes midfoot forefoot plate, and so I really like that plate because it's variable angle locking, and it's a little bit more robust than your standard mini fragment plate. So, and it has enough pliability that it will contour to the bone and it will flex down as you squeeze it down, and then as you go over, then those are your more standard mini fragment plates, which are a lot thinner and a lot more flexible. But they don't, at least in the Synthes system, they're not variable angle locking. So you're not gonna, it adds a level of complexity or takes a level of, what you can do out of it. But that's kind of what this ended up being.
Yeah, great. I like the mini fragment plates as well too. I mean, sometimes they'll even use the MTP plates as well too, because I think they contour well, and your set has variable angle locking too. But occasionally for real big ones, I'll use the distal fibular locking plate as well back there. It can contour well and sit down around these large posterior malleolus fractures.
Nice. And I think we talked a little bit about the post-op stiffness and whatnot. So here's the post-ops. And I think we went over this already. So onward. 71-year-old female. Actually, I don't know. We'll just go through the next two. There's two more pretty quickly. So 71-year-old female, osteoporosis, chronic kidney disease, right ankle pain, attempted reduction in the emergency department. So couldn't get it reduced. They call you. So you try to reduce it in the OR and the ED and splint it. You're going to X-fix it. You're just going to go ahead and fix it. Do you want more imaging first? What do you do next with something like that?
I like to X-fix these.
Yeah. Looks pretty unstable.
Yeah. I mean, for me, it's all dependent upon what my day is like, what else is going on, and if the skin looks okay. If the skin looks okay, the posterior approaches are really forgiving. So if the skin's all right, I may even, and I have time, I'll fix that day of injury.
Nice.
I mean, it's truly
maybe
healing.
not anymore. Maybe not after looking at this CT.
Yeah, it's bold.
Yeah,
So,
me,
the
This is
patient comes
P1.
in. Yeah, the ED just gets a CT scan right off the bat. So that's what we're working with. It did get X-fixed. So here's post-op films after the X-fix, and then the post-op CT scan, which I think is kind of the direction we'd all be going. So here's what we've got after the X-fix. And there's the 3D recon. Big posterior piece, big intra-articular piece with step off. All right, so let's say it's a couple days later, the soft tissues are ready. How are you guys going to treat it? You're going to leave the X-fix? You're going to fix it, fuse it?
I would try fixing it. Like chronic kidney disease scares me more than diabetes for the most part in terms of non-union risk. So I wouldn't try to fuse it unless, like, you know, I don't know, like that could almost be like a primary hindfoot nail depending on how sort of active the patient. If they have like a really poor baseline, like I might even just do a primary hindfoot nail, which sounds kind of crazy.
All right, since we're running out of time, here's what we did. So Atif, you decided to fix it.
This is my case.
Uh-huh.
They all really blend together. This is kind of what I do is that, so I did it prone. I like to use the Smith & Nephew plates because they're 3/5 variable angle plates. Smith & Nephew has two different flavors of their pilon plates. One is a very thick broad plate, which is used for that are like distal tibia shaft and pilon-esque fractures. And then they have these plates that are very thin, like this one, that are more for buttressing. And so this patient's old. They have very poor bone. You can see they're very osteopenic. And so the other nice thing about the Smith & Nephew plates and using bigger plates is that to use it as a buttress and to really get that buttress, you see that one screw that's just above the fracture. That's actually a 4.7 millimeter cancella screw. And so you drill with the 2.5 drill bit and you put this giant screw in there and you get this monster bite to then bring the plate down and use it as a true buttress. And then that screw also comes in distally. You can see it's a partially threaded screw. And so then you can get more compression at the joint line with the partially threaded screw, and you put that in there, and so that helps you out a lot. So I did this all through the posterior lateral approach, provisionally get the pieces down in the reduction, and then hold it with K-wires. If you go back that one slide, you can see that for the impacted piece, what I usually do is I'll take a 2.4 K-wire and I'll bend the blunt end and I'll use it like a bone tamp, either a 2.4 or 2.8 K-wire. And then under fluoro, I will tamp down the articular surface. And so we'll get that. And then you can hold that with a K-wire you can see on the middle X-ray. there's a K-wire then provisionally holding that reduction while you get your plate on. And so that's what she got. And then so since I was back there, I did my posterior 1/3 tubular distal fibula plate, which I love doing. And that's her deal.
Yeah, looks great. Any comments from the panelists?
When do you let her start walking? 3 months?
I mean, I'll let her start. This is like really rock solid. I mean, I'll let her start walking at 6 weeks.
Okay.
For this.
That's good.
I mean, you can tell me if it looks bad. I can handle it.
No, it looks awesome.
I would tell you.
That fracture would have me sweating. That articular piece in the center of the joint. But I think that's a good technique to get that K-wire in there and just tamp it down.
Because that's the major disadvantage of going prone in these posterior approaches. You're not going to see the joint. There's no way to see the joint. And for you guys that scope ankles, like there's no good way to put in a scope like you talked about. So it's really difficult. So it's all under X-ray. It's all indirect reductions.
All right. And the last one's just kind of a fun one. We'll just go through it real quick. So this patient, 72, alcohol abuse, cardiac disease, has had multiple surgeries on the foot with podiatry, is a poor historian, says he's had pain for about 1 week, but no clear mechanism. All right. So, and he's walking on this up until recently when it became a little painful. So here are the x-rays. This is in your office. So he comes into the office like this. Okay. And he's walking on this.
Yeah.
So you get a CAT scan. It's just chiclets and who knows how long of a chronic dislocation there. All right. So what are you guys thinking? You're going to just put him in a tall boy Arizona? You're going to put him in a big circular frame? You want to fix it? You're going to fuse it? Amputate it? I'll probably just send something like that to Atif.
Dr. Parekh.
I'll gladly take it.
All right. Ready?
Hindfoot
Go quick.
fusion now.
Sergio, what would you do?
Hindfoot fusion now.
Yeah. Everyone, Erik? Yeah.
Yeah, hindfoot.
Yep. I think that's a perfect indication for TTC there.
So this is my case, and so he was, I think by the time I operated on him, he was probably 2.5 to 3 weeks out from when his fracture was. He's a neuropathic diabetic. I did make some huge incisions to get everything to move, to take everything down and get it to move and actually get the ankle reduced. And then the key to success for this is that you have to use a long nail. So I use the longest nail, which is for Stryker, it's a 255 or 250 millimeter nail. You got to really engage the isthmus in order for this to be stable and for it to work.
Yeah, I think that's a good.
All right, guys, we got to wrap it up so I can get the next team out there. Thanks. Awesome session.
Thanks, everybody.
Thanks, you guys. Appreciate it.